Okay, all of the attendees in this on this webinar will be muted. If you do have questions throughout the program, please type them in the question box, which is located on the bottom half of your panel. You can see right here, type questions into the question box. I will be collecting questions throughout the webinar, and at the end we'll have about 10 minutes for a Q&A session. If you would like to verbally ask your question, you can do so by raising your hand next to the questions box, and I will call on you at the Q&A session, and you can ask your question verbally. I believe that is everything, so I will be passing this screen over to Monica to get started.
Thanks, Jessie, and welcome everybody. Thank you for joining us. Okay, our objectives for today, those of you who are attending will be able to list existing family-level measurement tools and approaches available for the use in healthcare research. We hope you'll be able to discuss examples of family research occurring in different contexts and family life stages. We'll give you some examples of those. And we hope you'll be able to strategize your own future family studies informed by an understanding of techniques and challenges encountered in current family research. Our agenda for today, we'll go through an introduction, we'll review some tools and methods available, we'll give you 3 different examples of research with families, sort of in a life stage continuum. Jerica will talk about childhood obesity, Ty will talk about adult diabetes, and I'll talk about late life chronic illness. We'll cover some lessons learned and then go to questions. So at this point I'm going to turn it over to Ty for our introduction.
All right, thank you, Monica, and hello, everyone. I think before we jump into the official title or focus of this, engaging families, in healthcare research, it's important to look at context. And as a brief introduction to that, the idea of collaborative care has been around with us, arguably forever, but in Western care, especially since the early 90s, when we started to see really an explosion of activity with research, with publications, increased momentum with organizations like the CFHA, et cetera. And the notion or the idea of collaboration between different fields has started to evolve, and this would be especially over the last dozen years or so, to also include families as active participators in that. And there is some empirical support that is little, and it's new, and it's not very much, but that shows that doing this is a good idea across a couple of different types of studies and physical health presentations, and the momentum is increasing. And as we do this, we're starting to see that impact or the influence that families have isn't a one-directional thing. It's a reciprocal thing, and it's something that really warrants a lot more attention and energy in our work. Next slide. So with that research that is, again, just starting, we're noticing that families, for better or worse, influence the individual people that inhabit that family. And we've seen this with cardiovascular disease, diabetes, chronic pain, arthritis. And the patient, in this regard, is officially diagnosed and struggling with something, has influence back in terms of that context that they're positioned within. And it could be good because now families are coming together to support and rally around this patient's illness. And then it can also be bad. And I think one of the places that we've seen that is in the caregiver literature, where people are struggling with Alzheimer's disease, for example, chronic illnesses that even in the best of circumstances can start to wear families down over time. As we have compared side by side standard care, which tends to leave families out in the waiting room, to research that does actively include families, either just by showing up and participating in the same thing or doing some kind of family-specific, intervention alongside with them, is that, again, they do outperform. Next slide. However, the ways that we're doing this in the real-life worlds of the clinic is way out ahead of the research. And arguably because of the face validity, I think that it makes sense. I mean, I don't think you have to convince people or work very hard to convince people that including families makes a lot of sense in terms of engaging their support, having them co-own the illness, instead of you go walk, why don't we go walk? Instead of, here's your diet, why don't we cook together, et cetera. But the research is a long way behind it, in terms of catching up. And the second verse is that oftentimes the dependent variables that have been looked at are pretty individually focused. So, I mean, yeah, we're going to include the family, but really what we're researching is the patient. And so most of the time the dependent variables are pretty individually oriented. Next slide. So when we think about, okay, well, how do we look at and how do we measure the family? And we go into all the different family measures that are out there. And this is where oftentimes we're getting out of healthcare proper and we're going into the field of family studies, family social science, marriage and family therapy, couple and family therapy, et cetera, of which a lot of it has nothing to do with medicine. We can start with these essays of general family functioning as a snapshot of sorts to see where they are. And, you can certainly do pre and post, but again, they're a snapshot of how this family is doing with or without the illness. Then there's measures that are specific to or sensitive to families that are struggling with illness, and those arguably are even better at capturing that motion picture of families as they change over time. Next slide. And we could be here all day long talking about the different ins and outs of these types of measures. There's certainly resources and references that we can make available regarding them. But these are examples of general family functioning scales that are out there that have the most use and most support. If you reviewed the literature regarding general family functioning scales, these are going to be the ones that are coming up the most. And they all overlap in the sense of that they look at key elements of the ways that families or any systems arguably function in terms of the ways that they communicate. How adaptable are they to change? How cohesive are the members within that unit? How do they problem solve, or do they problem solve? How do they handle interpersonal conflict? What are the respective roles, etc.? And they're all good in their own right, and they all have different places and different ways that it would make the most sense to choose that type of measure. And arguably, if you're looking at families as it relates to some type of health care, the ones that you would choose, or the one that you would choose from this list could, vary by the clinic, again, the different focus that you have. Next slide. When we look at scales that are better at that motion picture, specifically that are sensitive to chronic illness, it's a shorter list, to be sure, and most of the research so far that's done it is learning about families that are struggling with something. It's not necessarily research about how families are changing or evolving, or that we're going to do a family intervention now and we're going to see how it goes for others besides the patient. Most of this has been kind of a 1,000-foot view, to talk about families in which a patient is struggling with, fill in the blank. But that doesn't mean that it can't be used in research that pushes this notion of including families in healthcare. Common themes across these echo some of those general family characteristics in terms of cohesion, problem solving, etc., but they also go into the disease-specific types of impacts as it relates to the emotional functioning, the relationship breakdown or strengthening, how are families struggling with money, how are families struggling with their domestic day-to-day life roles or changing roles, etc. Next slide. So when we look at then, okay, here's these resources that are out in the literature, how do we use these? A lot of them are publicly available, so they're not going to cost us anything. Others are, but, if we get a grant, maybe we can cover that. It goes beyond that. Healthcare, as we know it, is very fast-paced. It's very complicated. There's a lot of moving parts, and certainly even doing research on a different type of intervention is in itself a tall order. And now we're going to integrate family, or we're going to look in this, how can we do this in a way that's not clunky, a way that's not going to be disruptive to the way that care is done? I mean, oh my gosh, this measure takes how long, to fill out, or oh, this measure needs, another person to come in and do the survey. It's not something that, people can necessarily fill out when they're waiting in the waiting room. And the answer to that is yes and no, depending on which measures you're using and where and when it's appropriate. And what we've found, and what we're starting to find, and you're going to see this in some of the examples that we're going to do here in the next several slides, is that all of the above can work, and all the above aren't necessarily going to work. And sometimes that's going to be in collaboration with the very communities that this research is positioned in, and then ultimately coming up with some kind of mix of qualitative data and quantitative data where you can triangulate those data sources, and you can triangulate the quantitative sources with other quantitative sources, or the qualitative sources with other qualitative sources, meaning multiple people in the family, across individuals and groups, etc. And with the whole being more than the sum of the parts, can certainly then inform the next steps or the steps after that about which measures can be used. In some of our studies, we've started small and then gotten more complicated as we've gone forward. And again, we'll be describing that here in a little bit. Next slide, and Monica, or Jerica.
So I'm going to take it here. We're going to switch gears, and we're going to start looking at the examples of how we're using measurement with multiple family members, and including these family-level types of measurements. And I'm going to tell you a little bit about a study called Family Matters, in which we are addressing unanswered questions about the home environment and childhood obesity. So as you can imagine, I'm talking about the life stage of families with young children. Next slide. So this study was built based on the difficulty we're having as a society with the obesity prevalence problem, and it being a major public health issue. And we're all well aware of the prevalence being doubled in children and tripled in adolescents, and trying to figure out what to do about it. There has been some recent leveling off, but this has mainly been with groups that are not diverse. And so we are with other groups of children. There's quite a bit of disparity still happening, and that is the group in which this study is trying to measure and to learn more about. Next slide. So we all know that the reason obesity is a problem is that there's negative health consequences, and here I have a list of some of the short-term problems that we're concerned with, and then the next slide I have a list of those that are long-term. You can see we're going from medical to also psychological problems. Next slide. The long-term ones, the difficulty with this is that childhood obesity tracks into adulthood, and so we then see some of the precursors that were short-term become these long-term chronic diseases that we don't want children to deal with. Next slide. So I wanted to also, just as a backdrop, put up the weight categories that are looked at in both clinical practice and research, and just point out that most of these probably look familiar, but the one that in research we carve out quite a bit is the 99th percentile, or the morbid obesity, and look at it somewhat differently, because those kids and families tend to have different responses to interventions and things like that. And so very common in research, that group is carved out and have very specific and specialized interventions targeted at them. Next slide. So this study specifically brought about all the strengths of the family studies field in medical family therapy, behavioral medicine, and tried to also link it with public health. And so family medicine in particular is situated quite well, because we have the family systems lens, we have the public health influence, and the medical environment through primary caring, which to reach some of these families. So because of the strengths of the family systems field, where we can target the entire family unit to potentially increase the effectiveness of what we're trying to do, and understanding some of the family system tenets that when we change some family members, it can change everyone, and of course we know that's for the good or the bad. So we're aiming at targeting good behavior in one family that can rub off on other family members. And then the sustainability is more likely in a family unit. And the other big benefit right now with focusing on primary care in the healthcare home is that with the Affordable Care Act, there's a lot of focus on integrated care and behavioral health, and we can deliver potentially some of these interventions that are family level through family medicine. Next slide. So one of the reasons we decided to step back and do an observational study is because many of the interventions that have been created might have been created a little too soon, before we know a lot about what's happening in the home. So they have intervened on diet and exercise, especially focused at the children and sometimes at the parent with the child. However, we've seen a lot of low to moderate success, and so they might have been carried out before we knew enough about the risk and protective factors in the home environment and across different race ethnicities. And so with that in mind, we knew we needed to learn more about the actual environments of diverse families that are dealing with obesity, or also children who are healthy, and learning more about that before we intervene. Next slide. So this is the push for the next generation of obesity research for researchers is to really go in depth as well as still keeping the breadth so we can learn about generalizability and findings that are representative. But before we move to that bigger picture, it's important to go more in depth. And so this is a study that was an R01 funded by the National Institute of Health, in which we're really trying to do that to get at some of the key reasons there are disparities. And so the 6 racial ethnic groups that are targeted, and in Minnesota we have a large Somali and Hmong group, and so we have representation from those groups in our study, as well as Hispanic, our Native American populations, African American populations, and then white. Next slide. So within that, as our context, being able to look across groups, we developed a mixed methods design that we then are able to, across those groups, get equal representation. And then we also stratified by weight status, which means we have families in which there's children who are not overweight, and then groups of children split equally that are overweight and obese, which allows us to look, again, at both protective factors. So in those homes where you have kids who aren't overweight, what are they doing well that we can learn from? And then the families in which they're overweight or obese, we're wanting to learn more about the risk factors, what's happening that's putting these kids more at risk. We also have an interdisciplinary team, which is clearly important when you're bringing in a systems perspective to include the people that have the expertise in different areas that will be affecting the family. So, for instance, we have myself, which is family studies and public health, but then also nutrition and medicine, kinesiology, which is the physical activity component, biostats, child development, for example. And then we combined the strengths of the fields of both family studies and epidemiology. So we have direct observational components of the study, and then this longitudinal cohort study that's part of the study. So next slide. So this is a 2-phase approach, and phase 1 is the one in which we're doing more of the in-depth piece. We're trying to learn more about the home environment and really doing more of the measures that are maybe more onerous and take a little bit longer. So we do in-home visits with families, and we do a few things when we're there. And we actually go 2 times. The first visit, we're teaching them about how to use an iPad, for instance. So we do what's called ecological momentary assessment, which is real-life capture of behavior going on in the real world. So they have an iPad that they carry for a 7-day, 1-week observational period in between the times we visit them. And throughout the day, randomly, they get a push notification, such as an email that says, push this link and it'll take you to your survey. In this survey, they're then asked questions about parenting practices, behaviors they're using with the child throughout the day. We also assess family-level chaos and closeness. So some of the measures that Ty was walking you through earlier, they have created some short forms of those. So for instance, the family assessment device has a 9-item general family functioning scale that works well because it's a shorter scale, but it's been validated, and you can use it to be able to capture family functioning. And I know for a lot of us, being able to find shorter scales that measure a really important concept like family functioning is really important because some of the original scales are quite long. And so Epstein himself created the 9-item general functioning scale so that for this very purpose. And then, for instance, other things about relationship satisfaction, we also measure stress and depression, because we're looking for those factors that then influence why a parent might serve certain meals at dinner. For instance, if there's a high level of stress throughout their day, might they choose to grab fast food instead of maybe creating a meal that has more fruits and vegetables as an option, for instance. We also do family interviews, and that includes the adults in the household. So we're really looking for, in these families, there's grandparents in the home, there's aunts and uncles in the home. In connection with that, we do what's called an interactive task, which comes from the family studies field, where you set up a scenario for the parents and children to interact and other adults in the household. So, for instance, in our situation, we ask them to plan a family meal, and they then, amongst themselves, without us intervening, go about figuring out who does what and how they're going to do this. So you can get a sense of roles, who speaks up, if kids act up, how do parents respond, and who does and doesn't take part. And it gives us the chance to look at interactive behavior in the moment. We also do a couple other things in the home, and that's one of them is a food inventory. While we're there, they come with us and we examine some of the food in their home. A block audit is looking at the environment around them, closest grocery stores or fast food, closest green space or parks. And then anthropometry is just the height and weight measures. So that is the in-depth piece of the study. Next slide, phase 2, we're taking it and becoming more broad or getting a breadth of understanding about these families. So what we've learned in phase 1, we're hoping to then inform phase 2. So if we learn a lot about the home environment regarding like a Somali family, for instance, and that group get-togethers on the weekend really influence what they feed their kids during the week, we'll ask more questions on our survey that we send out to a larger group about those types of get-togethers or different other contexts in which they interact in that maybe other groups don't so much. So phase 2 then basically takes, again, representative sample from each of our different racial ethnic groups, so around 200 each, allowing for more than one caregiver to respond to these surveys. And the surveys themselves then are really meant to be more asking better questions that we've learned from part 1. And those will also include some of the family measures that I mentioned before, like the family assessment device will be one, probably dyadic adjustment scale for marital relationship satisfaction. We also use sibling closeness scales to learn about the closeness of family members, and most of those have some kind of short form that we use. But again, this is not set in stone because, of course, we want the input from phase 1 to really know what we're going to put on our larger survey in phase 2. So based on all those results, we will then create an intervention that will be tailored to these different racial ethnic groups so that we can go in and intervene, hopefully on those risk factors that are really specific to the groups that we learned about in phase 1. And so we don't try to do something with a cultural group that wouldn't necessarily work for them. And that's the main goal, is the outcome is to really have tailored interventions. So that is the end of my segment.
The East Metro American Indian Diabetes Initiative is, obviously situated within our Native communities, and it's mostly here in Minneapolis-St. Paul, although it does overlap with other parts of greater Minnesota. So I'm going to dive in here and share a little bit about this work. Next slide. Just like with anything, it's important to give context in the arenas of health disparities, broadly defined, and we start looking at diabetes. It reminds me of how deceiving statistics and numbers can be. I mean, just like 0 and 10 average to 5, 4 and 6 average to 5 as well. And if you did a Google search on prevalence of diabetes in the United States, it's always changing. And unfortunately, it's always going up. But I think you'd find about 7% would be what you would find on a Google search now, which really doesn't tell you anything, because there's particular groups, ethnicities, areas of folks that have about a 1 or 2% prevalence of diabetes. And when we look at diabetes in the American Indian community, we have prevalence rates up to 50% in certain geographical regions and particular tribes. And so the 7% statistic does not hold there. This is, and according to our elders and community members here, a disease that's just decimating the American Indian people. Next slide. And the interventions that Western medicine has tried to do are limited in number and then also limited in effectiveness. Most of the diabetes interventions out there are with other samples other than American Indian folks, or they've represented very small numbers, certainly not representatively, within the research that has been done. And then research that has focused on American Indian folks in particular has generally been situated in reservation contexts, and oftentimes that's because of the availability or the presence of Indian Health Service and the homogeneity of your groups. But the majority of American Indian people do not live on reservations, and when they are outside of reservation contexts, and usually in urban areas, they don't have access to Indian health services, and the health disparities in those statistics from the previous slide, and then any other dependent variable you could pick that's connected to diabetes as an illness is going to be worse. Next slide. Alongside that, with historical trauma, being that they were, here first, and in the experience of colonization when European folks came over here, only about 3 or 4% of American Indian folks survived that. And there's a variety of different types of historical traumas that would fall underneath that umbrella, from the boarding schools to the American Indian Removal Act and the Trail of Tears, etc. The Mayo Clinic's early relationships with the American Indian communities that it's situated in, etc. And all of those things come together in a way that American Indian folks don't trust Western medicine. And Western medicine that is in place that serves them oftentimes misses the boat in terms of that historical trauma or the cultural appropriateness of what they're doing. Next slide. And so by using community-based participatory research, which is a type of research that honors the lived experience and wisdom of the communities that it's positioned in and works collaboratively, where there is a flat hierarchy between researchers and community members to co-create interventions. This has shown great progress in terms of working with and engaging American Indian communities in ways that are different than the top-down models of Western care. Next slide. Guiding principles, what I just said, so next slide. So the East Metro American Indian Diabetes Initiative covers the span of children to elders. Through the St. Paul Area Council of Churches Department of Indian Work, we have the FEDS, and that name is on purpose. That came out of the CBPR process. The FEDS primarily serves women and adult couples. The American Indian Family Center's men's group, created because most research has shown that engaging minority men in health initiatives is very difficult. And then the work through the Young Die Young Center and the St. Paul Public Schools targets kids. And all of these different interventions overlap with each other and are talking back and forth and sharing each other's wisdom and participants in everyday practice. Next slide. And so as we've worked on assessing what we would call in Western medicine a biopsychosocial spiritual frame, we learned as researchers that the idea or the notion of biopsychosocial as first advanced by Engel really wasn't first advanced by Engel. It's been a part of American Indian cultures and traditions for millennia. And it's really Western medicine's catching up to the idea of connecting these different systems that was a good change, of course, in Western medicine. But the collaboration then with the community says, we need, just like we need to walk in balance, as they say, to address and to connect with these respective systems, we also need to evaluate that. Patient-level assessments across the board, we've found positive outcomes as it relates to these community-based interventions. With A1Cs going down to about 7, we have about 20 pounds of weight loss for our adults, staying about 3 years out so far. Health behaviors as it relates to exercise, diet, and then disease-specific knowledge, and we assess that with the diabetes knowledge test, is consistently improved with our communities and a revolving door of patients and community members that participate in this. The family-level assessments, we have been in collaboration with the communities regarding what to do, because we started with qualitative interviews and talking circles, which is a culturally consistent and safe way of talking about difficult things in the American Indian community. And the idea or the notion of coming in with these Western models or ways of assessing families just really wasn't a very good fit. And through that series of conversations, we're starting now to adapt the psychological adjustment to illness scale in a way that frankly isn't reliable or valid from the outside in, but it's reliable and valid from the inside out. And so this item, or this measure originally, it's 46 items, and it includes vocational, domestic, sexual, extended family, social environment, and then the illness itself, and pulling entirely these sexual relationship part, redoing and rewording extended family questions, and now it's more items, but it is working in terms of what we're finding and what we're being able to track. Same thing with the family assessment device, although that one we haven't changed as much, but it was more integrated through conversations with the elders, looking at problem solving, communication roles, etc. Both of those tests are self-report, or we're using self-report versions of them, and that has been a lot more flexible in terms of the time and the context in which we're able to do that. Patient-family interaction, this came out of the CPPR process with that distrust for Western healthcare, and this is something brand new that we're going to be doing here this year. And the healthcare relationship trust scale gets at providers accepting patients for who they are. There's questions about that, about personal worth, about options, choices, and the communication and the collaboration that people have. And part of that is because an awful lot of our interveners and participators that represent medicine in these teams are medical students, and there is a great deal of energy and investment on the community to honestly help train the next generation of healthcare providers that can do this work better than the ones before them in American Indian communities. And then across the patient-family community level, we continue to do the talking circles and the CPPR forums because this is a moving target. We never do the same interventions the same way last year that we do this year because it's in constant dialogue with the community and in constant readjustment based off the results that we're finding. Next slide.
Yes, that's me. I'm here to talk about a project that we're carrying on at Allina Health. It's called Life Course. It's within the context of, in healthcare right now, we have a growing group of elders. All of us baby boomers are living longer, and healthcare has been so successful that we're living longer with illnesses that would have been a cause for death a long time ago or not too long ago. In addition, healthcare has really been operating in a mode where they treat and cure, and a new approach is needed to address in ongoing chronic illness. So the Life Course program is a study that's testing an intervention for patients and family members who are living with a serious illness. And for the folks in our project thus far, they've included people with advanced heart failure, stage 3 or 4 cancer, and stage 3 or 4 dementia. And they're expected to be in their last 2 to 3 years of life. We promote the use of palliative care practices earlier in the disease process. Most palliative care occurs in the last few weeks or months of life. It's associated with hospice work and is rooted in hospice work. It's based upon a whole person approach, so looking at not only the physical aspects of illness, but the psychological, the spiritual, the existential aspects. And it tends to and includes family in care. If you take a look at the palliative care continuum right now, what we've got on the left at the care management end is we have programs that are funded by health systems. They proactively help patients navigate care. Patients are typically identified because they experience a significant kind of event like a heart attack or a transition to a new care setting. The services in care management are time limited. They often last about 90 days, and they focus on the specific event that brought the person into that care management. On the right at the hospice end, we have programs that are pretty rich in resources and well-funded, but they only reach 50% of Americans who are dying. In between, there's a patched-together system of support. The most reliable support is inpatient palliative care, but it reaches only about 5% of people who are hospitalized for an illness. Patients and families are largely left to navigate multiple specialists and venues of care. There is some care coordination available, and it's quite helpful, but it's limited to a small number of specialty services, and it's linked to certain diseases like cancer and heart failure. To illustrate what this program does, I've got a picture of my parents on the left and my family on the right. This is my dad, Bob, and my mom, Lee. And then you can see from the family photo that there are a lot of us involved, and when you think about the illness that somebody might experience, my mom was not only experiencing a chronic illness, but the rest of us had our own perspectives, and we were impacted in different ways. About a year after this photo was taken, my mom was diagnosed with throat cancer, and she had surgery and radiation. She had to relearn how to talk and learn how to eat again, in addition to recovering from the physical effects of her treatment. She experienced significant weight loss due to the work of eating. This led to a growing weakness and frailty. Eventually, she was diagnosed with emphysema, and about 12 years later, she was diagnosed with cancer. In the midst of this, about 10 years after her surgery, my dad passed away, and she continued to live alone in their 4-bedroom home. It was the only house she ever lived in, and it was where she wanted to live out her life. She eventually became reliant on oxygen full-time. That kept her closer to home, but meant she was increasingly unable to take care of things at the house. So all of us were stepping in to help. This is the place where LifeCourse would ideally enter to help empower a family and the caregivers to live well with serious illness. Some of the challenges, as you can see from that example, that this period is characterized by an increasingly complex set of medical conditions and complexity in managing the illness. In addition to managing illness, there's a need to manage care from scores of providers who don't usually communicate with each other. One must also manage things at home so they can continue to stay where they are. Declining health often prompts individuals to think about their legacy and what they want to accomplish before they die. So this is a huge amount of work for one person to take on. In our study, right now we've actually got about 400 patients enrolled. Our numbers continue to climb, and we've got over 400 caregivers enrolled in our intervention. There's 201 people in the comparison arm and patients and 201 caregivers in the comparison arm. We recruit from our hospitals and some of our clinics, and then we also are in partnership with a couple of skilled nursing facilities in the community. The intervention includes what we call a care guide. It's a lay healthcare worker who works closely with patients and families, and they're supported by an interdisciplinary team of clinicians that include nurses, a pharmacist, a marriage and family therapist, a social worker, and a chaplain. The care guides go out and meet with people in their homes. At least monthly they have contact. They elicit what matters most to patients and help them kind of figure out what their goals for care would be, and we find that they're not just goals related to health, but they're oftentimes much deeper. Things like spending time with my grandchildren, getting to my family cabin, those sorts of things, taking care of my business. They normalize subjects that are difficult to talk about, like prognosis or legacy. They recognize needs that warrant follow-up with clinicians or other healthcare teams. They assist patients and families to use their own assets to solve the challenges before them, and they collaborate with other care teams, especially during transitions, to communicate the patient's story and help that patient feel known when they arrive at their new setting rather than having to repeat their story all over again. The background on the family intervention component, we hold what we call supportive care conferences, and these are essentially family conferences, but we conduct them in a much different way. We try to have them occur early on and as often as the family desires. Typically, family meetings in healthcare settings they occur at times of crisis or big decisions, and we want to have those things happen earlier. We invite family, provider, community members. We use a Skype-like technology to allow people to remotely attend. And then the idea is to explore individual and family perceptions and try to help families, empower them to prepare for future medical and non-medical needs. We have clinicians facilitate these, but the care guides attend, and then they provide ongoing contact and support for the family. The aim is to provide an opportunity to assist families to organize and plan for their future challenges and to help them organize their efforts in alignment with what's most important to their loved one. So if my family were touched by LifeCourse way back when my mom was trying to remain in her home, it would have been an opportunity for us to get information about my mom's illness and its effects. We would have been able to gain some insight into each other's perceptions and experiences, and that would have helped our working together. We could hear what's most important to our mom. The idea would be that we could also organize our efforts to help her stay in her home and make them more efficient than I think they were. It could help us know what to expect and what to look for, and that would facilitate planning so that when things happen, they weren't always the crisis that they often end up being when you don't get to plan ahead. Our tools, unfortunately, we don't use family-centered tools. There's a lot of concern at this stage of life with people who are suffering from so many physical effects around burden. So our team decided to stick with the common measures that go after quality of life and experience, which are big ticket items in healthcare. So we use the Facet PAL for patients, and then we created our own experience survey. And then we use the Promise 29, which is the, I think it's the NIH tool for care or for quality of life, and we applied this one for caregivers. And then they also take our experience survey. We've recently added a caregiver activation survey as a way to help us gauge how much support a patient might need, because we're identifying that we don't need heavy support for everybody, so we want to try to figure out how we can gauge the amount of support that folks utilize while they're within our program. And then my work is mainly centered around a qualitative component to learn about family experience during this life stage. So myself and my research assistant, we go out and we interview families as a group, and then we split them, and the assistant interviews the patient, and then I interview the caregivers alone, and that allows us an opportunity to talk about some things that are a little sensitive, particularly around caregiving and burden, loss of autonomy, and those types of things. I'm going to quickly go over our findings. If anybody's interested in much more specific findings, I can share those with you. But overall, we find that our patient quality of life is remaining pretty steady at a time when decline would be expected. Compared to our controls, our family members are seeing improved anxiety scores on the PROMIS 29, and care experience is more positive for patients and family members. Our qualitative findings are revealing powerful stories about the effect of the care team's ongoing support. We're seeing evidence of improved emotional health, confidence in yourself and providers, less isolation and loneliness, and positive effects on couple and family relationships. We've seen that work with the team has made important differences in how patients and families manage day-to-day, and spousal caregivers in particular appreciate the ability to talk about serious illness and plan for future events. So we've also put together some takeaways that we hope would be helpful for future research planning. We've provided some tools and examples about how you could include family members in healthcare research, but this doesn't mean that it's always easy work. So we hope that these considerations will be helpful to you as you think about your own research project. And we've organized them by system levels with assets and challenges. So if you think about on the system level, family engagement is routine in some service lines, and that's a place to build. There's a lot of technology available for some creative ways to implement research, and there's a desire growing for family research because health systems and providers are recognizing the value of including family members in healthcare. On the downside, the biomedical focus obscures the view of the family, and medical training hasn't really led people to see the big picture when they're working with patients. Providers within the system, there's not really a place for family work to be documented. Physical spaces often are a challenge. We've found too that there's a big misinterpretation of HIPAA. It's supposed to promote being able to share information, but it leaves our providers unsure about talking to family. The release of information process is a requirement. It's an extra demand, and it oftentimes only allows contact with one person, not more. There isn't any reimbursement for work with families, and there's no metrics that indicate services, or metrics that indicate services to families are not in existence. Amongst providers, we have a lot of committed, excellent service providers who want to know and help patients, but not everybody agrees involving family is a good way to go. Also, as a result of their training, few are trained to think about their care systemically. Scheduling is a hassle. Some folks have a resistance to turning control over to the families because that's not the way they're trained. They don't know how or what to document about family interactions. Some folks, we find their personal experience may make them resistant to including families because in the end, families are complex and messy, and it makes for difficult work. Amongst family members, there's a lot of strengths that can be leveraged. They can lead us to the important conversations and help us understand how to deliver culturally sensitive care. Working with families reveals more resources and information earlier in the process, and they're already working to manage illness, so we have a lot to learn from them. On the downside, I think one of the challenges is that families don't expect medical systems to interact with them in a very deep way. Medical language is a barrier. We were talking earlier, selection bias exists in that when you're in pediatrics, it's probably a more natural fit to work with parents, but when you're in the end of life, it's a little more difficult. Family context can influence their willingness to work with us, and life stage impacts their expectations and experience with us. So in summary, I'd say healthcare providers increasingly recognize that including families is important and a good idea. There is limited research on family involvement in healthcare, and there's almost no research on what works best for families, at least at certain life stages. The Accountable Care Act and changing demographics make this a historic time in healthcare delivery, so the time is right for new approaches and research that includes family. So at this point, we'd like to welcome your questions. It looks like we've got one on the docket.
Yes, thank you, Jerica, Monica, and Ty. That was wonderful. We have a question from Wayman Hinson, and I believe this is directed to Jerica. Wayman writes, is FACES too long for your purposes? Any dialogue with the authors in terms of a shorter version that measures the same constructs?
So I assume FACES is talking about the other common measure that's used to measure family connectedness, family adjustment, lots of different factors within family connectedness. So I actually use the family assessment device, and what it is there's a subscale called general family functioning, and it's actually a 12-item scale. In my study, we used 9 of them, so it's a 12-item scale, so which is a lot shorter than FACES, which is really long, and just the larger family assessment device, the FAD, it's actually quite long too. So using that sub-scale of the family assessment device, the general functioning scale, that one works fine, and it's a shorter version, which is what we all struggle with, is finding measures that are short and succinct but can still measure the construct we're interested in.
Wonderful.
This is Ty. I mean, one thing that I would also throw in or offer, the clinical rating scale, the observational version of it, is based off of the same foundation that the FACES instrument is, and that's something that is done by the clinician, but as the families are interacting with each other, either doing a task or talking about a difficult topic or whatever, the clinical rating scale gets at the adaptability, the cohesion, the communication as well, without the family having to fill out any forms at all. Now, the second verse to that, though, is that the inter-rater agreement between what families would say on a piece of paper, survey regarding their cohesion, adaptability, and communication, sometimes is quite different than what an outside observer would rank them or rate them as. And getting different versions or triangulating the two can sometimes be better than putting all of your eggs in either basket, respectively.
Wonderful. Thank you. Do we have any additional comments or questions? And if any of the attendees would like to ask a verbal question, feel free to click on the green hand and I will unmute you. Okay, wonderful. Any final comments from our presenters?
I mean, I think the one that I brought up and then has kind of just gotten rediscussed is one I run into a lot. So when you're trying to put together research within a medical setting or a public health setting, it's all about trying to get the most you can get out of families as far as being able to get information from them. And so if you're putting this survey together that's 500 items long, you're going to burden participants. And usually within the medical system, they don't want to take the time for family members to fill those out anyways. And so I struggle a lot with trying to find these shorter versions of measures. And so luckily some of them do, such as the FAD, which I was talking about earlier, have a short scale or subscale. That's not the case for all of the measures, and that I struggle with that a lot. So if you're trying to get more of like a survey that's going to go out to more people, it's a little more problematic. But if you're able to do some of this really in-depth stuff that I both myself and Ty talked about, and Monica to a degree too, where you're doing the interviews or you're doing the family assessment tasks with that's great if you can get to that in-depth level and have that time with families. It's just I find that, in research, especially in public health, they're wanting short items that can measure construct, and I struggle with that at times. And so, like I said, there's some that are out there, but there's still room for people to do that, to try to create those shorter measures and test them, and I'm happy if other people want to do that for me.
Wonderful. Okay, now, sorry, go ahead.
I was going to say, we struggle a lot with the topic of burden as well, but I've actually found, at least for interviews, I'm always worried about the time that we'll spend with patients and caregivers, but by and large, they almost always thank me and say that they find it helpful to be able to articulate what's going on for them, and it increases their insight. So I think that the issue of burden is a big one, and you want to be careful, but I think we also sometimes overestimate the negative demands that are placed by research, because oftentimes people find it very helpful.
Wonderful. Thank you so much. I believe, unless there are any last comments from our panelists, that that brings us to the conclusion of today's webinar. As a friendly reminder, this webinar will be posted on our CFHA website under the webinar section for webinar archives. And we hopefully look forward to seeing all of you in October for our annual conference held in Portland, Oregon this year. Registration has gone live, so please take a moment to look over that agenda. Thank you so much to our presenters again. Wonderful information, and we will talk to you all very soon.
Thank you.
Thank you.
Thanks, everyone.